On behalf of the team listed here, I'm pleased to present our research around health registers and Indigenous health equity in ascertainment and data quality and environmental scan. Ko waio, he uriho no nai tahu, ko Karen Wright tōku ingoa. My name is Karen Wright. I'm a senior lecturer at Te Kupenga Hauora Māori at the University of Auckland and a public health physician. This work is part of a broader project undertaken in partnership with the New Zealand Cerebral Palsy Register and funded by a Health Research Council Service Delivery Activation Grant. The register is a standardised dataset of birth and clinical information for people with cerebral palsy. Early findings suggest inequities in outcomes and ascertainment or recruitment of Māori children and young people. The broad project aims to support the register to prepare itself to comprehensively recruit Māori children, collect high quality data, and undertake effective Māori health equity research. Environmental scanning was one of the activities undertaken to achieve these aims. It's impossible to talk about Indigenous health equity without acknowledging that causation is complex, but equally important to recognise the significance of unequal treatment, racism, and privilege as determinants of health. This figure from Kamara Jones clearly illustrates 3 levels of racism and how they shape health outcomes. The most significant is institutional racism, and this level of racism is structural rather than individual and is seen in the way our institutions operate and who has access to power. In practice, it's often visible as inaction in the face of need. Our research was grounded in kaupapa Māori theory, and this quote from Leona Pihama captures some of what kaupapa Māori theory in practice is. It's fundamentally seeking to transform, and as such addresses inequity and power imbalance. As mentioned earlier, we utilised environmental scanning to identify strategies for recruitment and data quality for Indigenous peoples. Environmental scanning is a planning and quality improvement method that can be used to collect information to inform the design of health programs tailored to the needs of communities. We collected information from 51 health registers using 2 methods. First, a bespoke survey, and then web scanning of any registers that didn't complete the survey. The survey collected information about the register, explored perceived barriers to recruitment, and identified recruitment and data quality strategies. The web scan involved the searching of publicly available data located on websites. Data collection focused on the description of the register and identification of strategies. We collected a lot of valuable information, but I'm going to talk about 3 key findings today. First, equality versus equity. We identified register visions and aims from survey and web scan data. This was categorised into 5 groups listed here. What you may notice with this list is that Indigenous health equity is absent. This didn't stand out as a strong theme, and only 2 health registers in the web scan identified Indigenous health equity in their visions and aims. What we saw more commonly was egalitarian framing or equal treatment for all, regardless of ethnicity. The concern with equal treatment framing is that critical causes of inequity, such as racism and power imbalance, are left unaddressed. To the second point now, there were limitations in ethnicity data quality as described here. Interpretation of the web scan data is more limited as it wasn't always possible to identify if health registers were collecting ethnicity or not. Poor quality ethnicity data is a real and long-standing problem. It limits the ability to identify Indigenous peoples and restricts registers' ability to support Indigenous health equity. Finally, our third point, barriers and strategies. This table presents the themes from survey respondents for barriers to recruitment and data quality strategies. The themes to the far left column in the far left column are collaboration involving Indigenous peoples, systems, which was around ethnicity, data systems, processes, and protocols. Health provider and services was around recruitment and data quality actions at this level, and workforce included building capacity. In the web scan, data was significantly limited again, and Indigenous specific strategies were identified in only 1 register website. Again, many things could be discussed here, but I would like to point out some gaps and concerns identified in the breadth of strategies. To start with, barriers and strategies are orientated around personal behaviour and registration, and so structural causes like institutional racism and discrimination aren't addressed. Second, rurality is used as an explanation. This may be appropriate for some Indigenous people, but in New Zealand, and likely many other countries, the vast majority of Māori actually live in urban settings, so rurality isn't a proxy for Indigenous people. And third, collaboration is limited to advisory roles for Indigenous peoples, a role that is excluded from decision making and so holds low levels of power and self-determination. So pulling these findings together, we propose a draft framework to centre Indigenous health equity based on a tukutuku panel. This is an ornamental latticework used between carvings in Māori meeting houses, wharenui. Indigenous worldviews and Indigenous involvement represent the gold rods on either side, and the prioritisation of Indigenous health equity, the crossbars between. The weaving of gold and brown stitches, potama, represent the inclusion of high-quality data for Indigenous people, standardised evidence-based systems and protocols, workforce development activities to support capacity and capability to achieve Indigenous health equity, and actions to address institutional racism and discrimination. And finally, partnership between Indigenous and non-Indigenous peoples is critical and fundamental to success. I will leave you with our framework and some key messages. First, health registers, and specifically CP registers, can support Indigenous health equity, but this requires comprehensive recruitment of Indigenous people and high quality data. This leads on to our second point, that achieving equity requires deliberate action, and so it is essential that equity is named, prioritised and acted on. And finally, a CP register that meets the needs and rights of Indigenous peoples requires the involvement of Indigenous people beyond advisors. Importantly, this requires meaningful partnership and power sharing. So I thank you and I look forward to your comments and questions.